All right. So we'll get started today. Just wanted to say good afternoon, good evening, good morning to everybody that's joining us today. Thank you for joining us to TAPS, our Australasian Pleural Seminars, monthly series highlighting pleural disease on the first Wednesday of every month. Joining us today, we're honored to have Dr. Steve Walker, who's a consultant senior lecturer at the University of Bristol, and honorary respiratory consultant at North Bristol NHS Trust. We're excited to have him here today to talk to us about spontaneous pneumothoraces and the recent guidelines that were just published fresh off the press. So, we're excited to get his insight as to, what he would do and what the recommendations are. What I will tell you is, if you have any questions, please write them in the chat box so we can see them and discuss them towards the end of the seminar today. And before we get started, I just want to highlight for next month, we will have Dr. Taj Seghay from Sydney talking about fluoroscopy. So be sure to join in then. But without any further ado, I'll give you Dr. Steve Walker.
Thanks for the very kind introduction, and thanks, Gary, for the kind invite. I'll just share my screen and try and get started. Can people share my screen? See my screen?
Yep.
Yeah. Okay, great. Okay. Fantastic. So thanks. And it really is a great pleasure to present these European guidelines on the management of spontaneous pneumothorax. They were published in May this year in the ERJ, but also in the European Cardiothoracic Journal as well. And I'm really looking forward to discussing the recommendations, but also having some discussions at the end, which I think is the exciting bit about these seminars. And I've watched your other seminars with great interest. I saw your inaugural one about persistent air leak and one about conservative management. And so hopefully this talk will add to that and give us some more stuff to talk about. So the guidelines came up with 12 recommendations. 9 of those were PICO recommendations. So those are clinical recommendations using the grade criteria. There were 3 other recommendations, which were narrative recommendations, which are more sort of patient-focused recommendations formulated using narrative synthesis. We separated the guideline up into optimal management of pneumothorax. So in terms of the initial management of pneumothorax, the management of persistent air leak, and also the final section was about recurrence prevention, which was mainly focused on surgical preventative techniques. I won't talk about the last section so much just because of time constraints, and also there isn't very good evidence base for any of those differing techniques. In terms of the guideline group, it was a very pan-European group, as you might expect, with the rest of the world represented by Professor Gary Lee in Western Australia, which we were very thankful for. It was an equal split between surgeons and respiratory physicians, and so all sort of interested parties were represented. And the group had lots of evidence to look at. So we looked at thousands of articles and studies and publications about the management of spontaneous pneumothorax, including some of the sort of landmark studies that you'll all be aware of. The Brown study from Australasia, the RAMP study, which is a study on ambulatory care, that was performed in the UK, and the Olsen study, which was a study in Denmark about first-line surgical management for spontaneous pneumothorax. And these, I bring these up particularly as these are quite practice-changing papers, but they were supported by a wealth of other randomized control trials and non-randomized studies. So just to get us in the frame of mind, I'll have an example patient. So we've got Johnny here. I think he's quite a classic patient. He's a 23-year-old. He presents 2 days with dyspnea. He's physiologically stable. His saturations are fine. Rest rate is 18, slightly high. Blood pressure 120/70. We'll say his heart rate's 95. He can comfortably mobilize around the emergency department. He's got no medical history. He's a bit of a smoker, but never had a previous pneumothorax. He has, however, got a large right-sided pneumothorax, as you can see from that picture. So I can't really ask for any audience participation using this format, but maybe just have a think amongst yourselves of the audience what you would do. Would you take a conservative observational approach to Johnny? Would you use short-term needle aspiration to try and bring up the lung at a once-off procedure? Would you use an ambulatory device, so some sort of Heimlich device or inbuilt flutter valve device? Or would you opt for early surgical management? Are you worried about future recurrences in Johnny? And do you think a surgical procedure at the first line would be the optimal approach? Or would you opt for a chest drain, which we're all very familiar with and know how to use? Just for your interest, when I presented this guideline at the ERS Congress last year, the overwhelming response was chest drain. And what I hope is that this guideline shows us that there are other options, good options compared to chest drain that we can offer Johnny. So I'll start off with our first PICO. These are in no particular order, but the first PICO we looked at was conservative management. And what you can see here is that, you know, conservative management led to better outcomes really across the board in terms of outcomes that we ranked as high in the guideline methodology. The predominant study that you'll be aware of was the Brown study, which was a study conducted in Australia of 316 patients with large primary, moderate to large primary spontaneous pneumothorax, randomized them between conservative care and a standard care of chest drain insertion. And what that study showed is essentially that conservative care in that study population was a safe approach, and that led to good outcomes. So based on that and other studies, the guideline panel suggests conservative management of primary spontaneous pneumothorax. The important thing is that it's regardless of size. So, and this is a big change from previous guidelines. So no matter how big the pneumothorax is, you can manage that patient conservatively. And I think that a message has been strengthened by subsequent publications from the same study group. There is a bit of couching in the language about that these patients shouldn't have a high symptom burden and they should be clinically and radiologically stable. The next PICO question looked at needle aspiration. So this is short-term drainage, usually draining up to 2.5 litres using a cannula or a similar device. And this was comparing against chest drain. Now, this is the most well-studied area in spontaneous pneumothorax. There's been multiple studies, RCTs, looking at this, and we included 7 RCTs comparing needle aspiration versus chest drain. And what it shows is that needle aspiration leads to shorter length of stays and is probably more comfortable for patients. And so based on this, the panel recommends that needle aspiration should really be used over chest drain for the management of PSP. And because of the amount of evidence available, that was a strong recommendation that we made there. The third PICO question looked at something called ambulatory management. So ambulatory management is essentially using a device that has got a one-way flutter valve as opposed to using an underwater seal chamber. This flutter valve can either be attached to the end of a chest drain or it can be inbuilt in into the same device, so you don't require to insert a chest drain first. Now, there have been a few studies looking at this. The largest RCT was the RAMP study performed in the UK, which looked at 238 patients with primary spontaneous pneumothorax and compared them to an inbuilt flutter valve system compared to a standard of care. And when you take all this evidence together, ambulatory management, perhaps unsurprisingly, led to lower length of stays and potentially fewer overall procedures as well. Based on this, the panel suggests that ambulatory management should be used for the initial treatment of primary spontaneous pneumothorax, but it does couch that in that it should only be used in centres with appropriate expertise and pathways to manage patients as an outpatient. To manage patients ambulatory, really, it isn't just about the device itself, it's about the pathway and about the support services so that you can send patients home safely, that you can review them early for removal of the device, but also if they have any complications. The same actually can be said about conservative care, and I think that's maybe a little bit of an unappreciated fact as well, that if you are managing patients conservatively, that really is a form of ambulatory management, and it requires good outpatient setup to do safely. The final PICO question about the initial management of primary spontaneous pneumothorax is a bit of a curveball. This is about early surgical management. We do know that recurrence rates in primary spontaneous pneumothorax range from about 20 to 30%, depending on the study that you're looking at. And there is some interest about whether using surgery at first line can lead to superior patient outcomes. It's important to note that this is after stabilization with chest drain. So all of these studies looked at patients who were admitted, had a chest drain inserted for the primary spontaneous pneumothorax, and then typically randomized them at that point to having surgery as a first line procedure or not. The biggest study of this was the Olsen study, which was, as I said, conducted in Denmark. And what, unsurprisingly, I think, surgical studies led to patients randomized to surgeons had lower overall recurrence rates. And based on this, the panel suggests consideration for early surgical interventions for the initial management of PSP, but only in patients who prioritize recurrence prevention. I have to say, though there is RCT evidence that shows overall low recurrence for surgical techniques, the papers and the studies didn't really have a lot of other patient-related outcomes, which I think would have really strengthened any recommendation that we could make. So this really is a conditional recommendation based on low certainty of evidence. And now we're sort of led with a good problem, but it is a problem in that we've got various possible solutions to managing the initial presentation of pneumothorax. We've got observational care, we've got needle aspiration, we've got ambulatory care, we've got chest drain, and we've got surgery. And that poses a bit of a problem for us as clinicians, but also as patients, about which one we would choose. And as you can see from the recommendations, we've recommended each, though we've couched it in some conditional recommendations. What we've created here, and it's expanded upon in the guideline document, is a decision aid, which potentially helps clinicians and patients make that decision. So looking at some of the key, what we thought were key outcomes, and presenting that in a diagrammatic form might be helpful. So the next bit of what I wanted to talk about is persistent air leak. And I saw the excellent talk that was given earlier in the TAP seminar series about persistent air leak. So you may all be familiar with some of the options available to it, but I wanted to talk about what the guideline talks about. So this is another potentially classic example. So Frank is a 67-year-old with secondary spontaneous pneumothorax. He's got severe COPD, he's got severe pulmonary hypertension and respiratory failure, and he's got a drain in situ that has been bubbling for 6 days. Now, based on these comorbidities, he's probably not going to be a great surgical candidate for surgical correction of his bronchopleural fistula. So the question really that these PICO questions is about the optimal medical management. And again, not really any, I can't really have any patient participation here, but maybe have a think amongst yourselves what you would do. You'd be aware of endobronchial valves, autologous blood patch, use of thoracic suction, Or there are other options, and maybe there are other options you would do in your center or you would consider. So looking at what the guideline looked at, the first one we looked at is autologous blood patch. So this is a technique that you'll be familiar with, where you can instill the patient's own blood, typically via a chest drain, with the aim of essentially forming a clot over the bronchopleural fistula. It's been fairly well studied. There's been 3 RCTs looking at autologous blood patch, as well as various non-randomized studies. And they all seem to suggest that using autologous blood patch leads to lower duration of hospital stay, but also lower duration of air leak. But I would say that the studies have the faults. They're very heterogeneous in design and patient selection, and that did affect the strength of the recommendation we could make. So the panel suggests that autologous blood patch can be considered in persistent air leak who are not fit for surgery. But as I said, it's a conditional recommendation based on low quality of evidence. The next PICO question is looking at something called bronchial valves or endobronchial therapies. Essentially, these are therapies where you can block the bronchial tree, creating an occlusion and localized atelectasis to stop air flowing to the bronchopleural fistula. There are various therapies available, some more advanced than others. The literature based on this is predominantly non-randomized studies, and really actually non-comparative studies, which really does limit any strength of recommendations we can make about these devices. They do seem to lower the duration of air leak and have quicker resolution. There was only one randomized trial looking at that. That was the Zhang trial, which used a slightly different device than what we use, particularly in Europe, which is something called a bronchial occlusion spigot, which is essentially a silicon sort of plug. But that did show that occluding the bronchial tree led to shorter length of stays and a shorter duration of air leak. But based just really on that one study and a series of other non-comparative studies, the guideline group felt there wasn't enough evidence that we could make a recommendation for or against bronchial valves. That doesn't mean that you can't use them. It just means that we can't make a recommendation that we should be using them or we shouldn't be using them. Surprisingly, there's actually a similar picture with suction. Thoracic suction is probably something we're all familiar with, using negative pressure to try and reinflate the lung quicker. It's got its advocates who think that reinflating the lung quicker will create apposition between the visceral parietal pleura and lead to optimal healing of the defect. He's also got people who argue against it, saying that drawing air for a bronchial pleural fistula would actually impede wound healing. Surprisingly, for something that's been around for so long and it's quite a simple technique, it hasn't got a very good evidence base. The only RCT is done in 1982. It was an underpowered study. I think they recruited about 40 patients. They were aiming to recruit over 100 patients. It was a very mixed population of iatrogenic, spontaneous, and post-surgical patient. And it didn't show a difference between suction and non-suction. I don't think that means that there isn't a difference, but that study was never going to show that. So basically, because we had no evidence, the guideline could not make a recommendation for or against suction. Again, that doesn't mean that you can't use it. It just means that there isn't the evidence for or against it. And this is a flow chart. I think every guideline should have a flow chart, that they are quite difficult to incorporate within in guidelines. This is just a summary of really what I said about the initial management of primary spontaneous pneumothorax, and includes all of those initial 4 PICO questions. You can also see that there's a section on secondary spontaneous pneumothorax, I haven't really talked about the initial management of secondary spontaneous pneumothorax, though there are recommendations within the guideline about it. Essentially, it's a pretty much evidence-free zone, and that's why I haven't gone through it today, though it does mention in this guideline about how to manage persistent air leak. And I'm not going to go through these, but I just thought I'd sort of flag that we've got some excellent narrative questions, which I think are worth a read within the guideline. I think the ERS methodology is good, that it allows us to do things like this. That questions that really can't be answered in a comparative PICO type question, but can be answered in a more narrative way. So about predicting clinical course, about fitness for surgery, about patient-centered implications. I think all very important questions. And so there is some, I think, some good work in the guidelines about that. So hopefully that's provided us some fodder for discussions and some questions. And thank you for listening. I will end at that point.
Brilliant. Thank you, Steve, so much for that. You've set a high bar for international presenters now. I'd be remiss to say that, and mention that you're our first international star on TAPS here. So thank you for that. And thank you for that wonderful update. I think and as we wait for, some of our participants to answer some questions, put some questions in our chat box, I will kind of start with one question that I kind of have in terms, you mentioned autologous blood patch. So would you be able to comment on kind of, how I guess, well it works in terms of surgical or post-operative versus medical kind of etiologies? Any thoughts on that?
Yeah, so this guideline was focused on spontaneous and not post-operative. So, so the recommendations and the evidence is focused on that. There is actually probably more evidence in post-surgical patients, and that's where it was initially used, is in post-surgical. And to be honest, a lot of what we do is actually extrapolated from that. But I wouldn't be able to make a comparative between the two. I don't think so. But I think essentially what it seems is that both of them, it seems to be a promising technique. I don't think it's a magic bullet. And to be honest, I don't think any of these techniques for persistent air leak are a magic bullet. None of them seem to work, in the next 5 minutes or the next hour or whatever. And a lot of these studies required sequential administrations of blood patch. So some of these patients had 2 or 3 administrations. So I think that needs to be bared in mind. But it is a low-cost, simple intervention. And the risks of pleural infection, which have sort of been touted, weren't borne out in the randomized trials. That doesn't mean that they don't exist, because randomized trials sometimes aren't the best way of picking these things up, but they definitely weren't shown or flagged up in the randomized controls trial. So I think a promising technique in a challenging population.
Absolutely, yeah. Thank you. It's insightful. The other question I'll kind of ask too is that in terms of an outpatient setup, to take care of these patients conservatively or with an ambulatory device. Any wisdom on how you would help guide a program or, a group looking to do that? Because I think that's one of the big kind of components that prevent people from offering these more conservative management options. We're fortunate here that we have a great pleural group that can follow up all these patients anytime we want, essentially. But I mean, we're very fortunate to have that. Not most places won't, I think.
Yeah, I think it's difficult. I think there's various degrees of difficulty with it. And I'll be upfront. The ambulatory sort of devices, the pleural vents, haven't been taken up widespread in the UK. I think we have to be honest. Whilst and maybe the guidelines will change it, there are definitely barriers to implementation, even when there is evidence there. So, and some of those barriers are to do with training of front door staff. So the emergency physicians, they've got a lot on their plates trying to teach a load of busy clinicians about a new technique is challenging. and then, as you mentioned, the sort of the follow-up service is challenging itself. Again, we're lucky in that we do have a good outpatient service, but I think the reality is, and you'll know this, is that pleural medicine is essentially an outpatient service now, and not just for pneumothorax. So for, and predominantly for malignant pleural disease, it is an ambulatory service, and we are managing patients as an outpatient. So trying to sort of build, I think this is another reason, if people are making business cases at their own local hospitals, that they need a good reactive ambulatory pleural service to deal with the, with the malignant pleural effusions, with the, with their indwelling pleural catheters. This is another string to that bow, and that there is we are going to be managing pneumothoraces as outpatients, and whether that's conservatively or whether that's with an ambulatory device, that is the direction of flow, and that will save hospitals money. It will save hospitals money. So I think there are challenges there, but I think it's about using that evidence, particularly the sort of shorter duration of hospital stays, to try and get hospital managers to sort of help you build up those services.
Absolutely. Oh, thank you. We have a participant asking, how often or frequently should a patient managed conservatively be reviewed?
Yeah, it's good, really good question. So you know from the Brown study that they really review them within 48 hours after discharge, and that's the evidence that we've got. I think as you get sort of a bit more comfortable with these things, I think you can extend that, and we definitely do extend that. And I think it partly there is a bit of clinical acumen to that, in terms of how worried about the patient, and things I think about is one, how long that patient's been symptomatic. So really trying to get a feel for the trajectory, and whether I know, if they've only been symptomatic for a couple of hours, I'm a little bit more worried about where that trajectory is going to, unless they've been symptomatic for 5 days. I look at the clinical stability, I look at where they live. But I think I would always follow up someone, usually within the first week is what I would do. But if they're stable at that point and it's getting better, I know that it's going to get better. And so I'm pretty relaxed about further follow-up after that, because essentially all I'm doing is going to get an X-ray at some point, just to make sure it has resolved, so they can get a flight at some point.
No, exactly. Yeah. No, great. Thank you. Another question we have is regarding commenting on endobronchial glue installation in persistent air leak over a blood patch.
Yeah. So we didn't look specifically at endobronchial glue within the guideline, and I sort of suggested that there are actually quite a lot of different iterations you can do for persistent air leak. There are actually quite a few different management strategies, and endobronchial views are an exciting avenue, I think, but really case studies. That's really all we've got, is a few case studies about endobronchial glue. So not really enough to make a guideline, a PICO question about, and we've got to be quite careful when we're making PICO questions that we don't make unanswerable PICO questions. So I think it's an exciting thing, and I think if anyone's doing it, I would encourage them to sort of document it, and so you can present it. I think I don't see why it would work any less well than any other bronchial therapies. I think the thing about bronchial therapies is it's about sort of identifying exactly what the air leak is, and making sure that you're dealing with collateral sort of ventilation, and doing it in a safe way. I think I'm not sure whether the differences between how you do it matter, though I don't know that for sure. I think that's where we need more evidence.
Yeah, no, and I think you nailed it. You hit it right on the nailed it right on the head. There is that the collateral ventilation and really isolating the segment or the area is probably the most challenging thing to do. And yeah, like you said, there are a few different options. So I think that's the one nice thing. We have a few tools in our arsenal to kind of help manage that. But it really is kind of isolating and figuring out if there's collaterals or not. So and then quickly, just as we end, I will ask Gary put up a question in terms of, there are many areas with little data. if you were to prioritize one or two areas, projects, what would you kind of recommend?
I think persistent air leak. I think we don't in the patients who aren't fit for operations. I think I think it's a real challenging situation. I think it's really challenging for us as respiratory physicians. I think it's awful for patients. And I think there's I think we need more evidence and maybe more solutions, to be honest. You know, about how to manage it.
Steve,
Absolutely.
when I was on the panel, I was surprised at how diverse the surgical opinions were in terms of what is the right surgical approach. And it kind of reflects what happens in my hospital, where surgeons trained in different places. There's an entirely different approach. And I think a lot of time the respiratory physicians don't actually understand that is potentially an issue. They just write a referral, send it to the surgeons and say, this patient go for surgical pleurodesis, without realizing that this is a really umbrella term. Without anyone agreeing on which is the best method, can I just ask, if you have a pneumothorax and you fail conservative management and you have to have surgery, what would you want your surgeon to do?
I think as a great question, and I apologize for not touching on the sort of the two surgical PK questions, but as you sort of alluded to, there was not consensus there, and I think it's important to sort of say for the audience that there's three issues. There's the access issue. So VATS versus thoracotomy, I think that's been answered, and I think everyone goes for VATS. So that's really how you get into the pleural space. The second issue is whether you need to essentially chop a little bit about the lung out, so whether you need to do a pulmonary intervention or not, and a blebectomy. And then the third issue is whether you do and what and how you do a pleurodesis type procedure. So how you glue the visceral and parietal pleura again together. So there are various steps to that, and as you sort of say, particularly for the pulmonary intervention and the pleurodesis bit, there is a massive amount of variation internationally, and probably even sort of within some departments about what they do. I think I don't really want to sort of put my head on the chopping board with the surgeons about sort of saying which I would do. What I would say is that there are while it is evidence based at the moment, there are some randomized controls coming along the way. So there's the WAPS trial, which is looking at various of these questions in terms of sort of pleurodesis. I do think that pleurodesis is an important part of it, is what I would say. I think that's my gut feeling, and it'll be interesting to see whether the evidence bears that out.
But you would want abrasion or just talc or both?
I've seen someone do an abrasion, and I don't think I'd ever want that. But that's not to say that it doesn't work.
If it is me, I would want everything, since I'm on the procedure, to try to have the least amount of chance. But
no,
so even on chairs for today, that we got diverse opinion. What would you have to do then, Dhaval?
Yeah, I kind of agree with Steve. After seeing an abrasion, I don't know, that doesn't look exciting.
Well, okay, well, there you go. So every opinion is represented in the panel. So good.
Very good. All right, so we are a bit over time, but again, we thank you, Steve, for joining us today. Really appreciate you taking the time and your expertise to update us. Again, just a reminder to the group, please join us next month for Taj Sagay talking about fluoroscopy, and we'll see you then. Take care.
Thanks, everyone.